Good morning. My name is Sarah Spinella. I'm one of the first year Women's Health Fellows, and I'm going to be talking to you today about contraception.
So, as I mentioned, we're going to be talking today about contraception. The reason that this is so important and so worth your time, even now with everything going on, is that contraception is about family planning. About 45% of pregnancies in the United States are unintended, and contraception helps men and women prevent and space their pregnancies so that they can become parents at the time that's right for them. I also wanted to add here that a lot of contraceptive counseling can be done very easily over telehealth. There's not a lot of physical exam requirements, and we can do a lot of this prescribing over the phone or using video visits. So it's very appropriate to be talking about it right now during the time of COVID-19. I do have a couple of specific goals for you by the end of this session. I want you to be able to list the commonly used methods and their pros and cons. I want you to know about how to practice patient-centered reproductive counseling, which really reflects the patient's goals and preferences. And I want you to feel confident in your ability to leave this session being able to prescribe contraception and troubleshoot common contraceptive problems as early as this afternoon. The agenda for today, we're going to start by talking about a couple of resources that I love that I think you'll be able to carry with you throughout the rest of the week and month, and that you can use in real time to help you with contraceptive decisions. We're then going to go through a couple of the nuts and bolts that I have seen many people struggle with, and then we're going to spend the bulk of this time working through contraception cases. There is new material as we work through the contraceptive cases, and I also think that's where a lot of the long-lasting learning will occur, so I hope you do spend some time with the cases. All right, I just wanted to start off by making a couple of very practical recommendations, which is that it is not possible for me to teach you every single thing you need to know about contraception in an hour. That being said, I love these two apps. They're available, they're free, and you can use them point of care to help you when a question arises during a contraceptive counseling session. So I'd like everybody to pause the video right now and download the CDC MEC app, which gives us information about medical comorbidities and how to make contraceptive recommendations when patients come to us with pre-existing conditions. I'm also going to recommend that we download the Contraception Point of Care app. This has very practical step-by-step instructions for providers on how to initiate contraception, how to use emergency contraception, and how to counsel patients when they've missed a pill. The next several slides I've actually taken directly from that Contraception Point of Care app. There are over 200 FDA-approved contraceptive brand name pills for us to choose from. And that is great because it means there's a lot of options, but it can be challenging for us as providers to know how to even begin to choose a particular contraception pill once we've had a conversation with our patient and she's told us that she's interested in combined oral contraceptives. The first step is to just choose a dose of estrogen. Estrogen comes in 3 doses. Low dose estrogen is 20 to 25 micrograms. Medium dose estrogen is 30 to 35 micrograms. And high dose is around 50 micrograms. Though I'll be very honest, I never see patients on high dose estrogen. I myself almost never prescribe high dose estrogen. And so for the purposes of being new at contraception, I think you can almost pretend that high dose estrogen doesn't exist. A common question is, how do you choose between low and medium dose estrogen? As the dose of estrogen increases, obviously the patient is more likely to experience estrogen-related side effects. That's things like nausea, vomiting, bloating, and an increased risk of DVT or PE. At the same time, patients on lower doses of estrogen are more likely to experience breakthrough bleeding, which can be very bothersome to many patients and can actually make some forms of hormonal contraception intolerable to patients. Because of this, I tend to start at about a medium dose of estrogen and then go down to a lower dose if the patient starts to experience a lot of estrogen-related side effects. The next step is to choose the generation of progesterone. This is a little trickier because I don't know that we all already know different generations of progesterone. I'm going to go through the different generations and then tell you how I think about this. First generations of progesterone are norethindrone and ethanodiol, which I clearly don't prescribe a lot. Second generation progesterone includes levonorgestrel and norgestrel. Third generation progesterone is desogestrel and norgestimate. And finally, there's a fourth generation or a non-generational progesterone called drospirenone, which is what we see in birth control pills like Yaz or Yasmin. And the thing to know about drospirenone is that it does increase the risk of PE and DVT, much more so than the first, second, or third generation of progesterone. Fourth generation progesterones, though, are anti-androgenic. They are drospirenone is actually structurally related to spironolactone, and so that is why some patients were traditionally placed on drospirenone and why some patients prefer that medication. In theory, as you move down the generations of progesterone, they become less androgenic. So the idea would be that desogestrel is less androgenic than norethindrone. In reality, the clinical significance of that has been called into question recently. I will tell you, I often prescribe second and third generation progesterones. And I often favor levonorgestrel because I'm already comfortable with that form of progesterone from other forms of hormonal contraception, including levonorgestrel IUDs. The final step, and probably the least important step in some ways, is to choose whether I'm going to prescribe a monophasic or a multiphasic formulation of the combined oral contraceptive. Monophasic formulations mean that every active pill in the contraceptive pack has the same dose of estrogen and the same dose of progesterone all month long. The advantages of monophasic dosing is that women tend to experience less breakthrough or unanticipated bleeding on monophasic formulations, and it's easier for a woman to control when she has a breakthrough bleed. So, for example, if she is planning to go on vacation, or if for some reason it would be inconvenient or unacceptable for her to have a period on week 4, she can end week 3 with a monophasic birth control formulation and start right up again with week 1 of the next month and skip the withdrawal bleed that month. In contrast, in multiphasic formulations of oral contraceptive pills, there are dose changes depending on the week of the month. So this graphic that I've included is from orthotricycline, and it shows that the first week of pills has a little bit of a lower dose of progesterone than the second week of pills, and those doses change throughout the month. The idea behind multiphasic pills is that we know that women who aren't on combined oral contraceptive pills do have fluctuations in their hormones throughout the month. And so the idea was that these multiphasic pills might more closely mimic what happens, quote unquote, naturally in women who aren't on birth control pills. As this has been studied, we do know that monophasic and multiphasic pills are equivalent in terms of their side effect profiles and pregnancy prevention. My general practice is to favor monophasic over multiphasic pills. That being said, for patients that have been on, say, orthotricycline for years and love it, I'm happy to continue them on multiphasic pills. So we talked a little bit about the strategy of choosing an estrogen, choosing a progesterone generation, and then thinking about a multiphasic pill versus a monophasic pill. I wanted to give you just a couple of brand names. There's nothing special about these brand names except that they're the ones that I happen to know and that are easily on formulary at the VA where I work. But this way you have a couple of pills in your back pocket. So if I am starting an average patient on combined oral contraceptive pills, I usually pick a medium dose estrogen, a second generation progesterone, and for me that combination is levonorgestrel and estrogen at 0.15 milligrams and 30 micrograms, and that brand name is Livora. If for whatever reason the patient is particularly concerned about androgenic side effects, or if I'm starting this patient on the pill in part to reduce androgenic side effects like acne, I often will choose, again, a medium generation, or rather a medium dose of estrogen, a third generation progesterone, and for me at the VA, that is called mononessa. Finally, in my patients who experience significant estrogen-related side effects, I will often switch to a lower dose of estrogen. So again, a low dose estrogen, a second gen progesterone, and for me at the VA, that's called Stronix. All three of these that I just presented are monophasic birth control pills. If I'm choosing a triphasic birth control pill, I often choose orthotricycline. All right, so we've talked a little bit about how to choose a combined oral contraceptive pill. The next question is, how do I actually start a combined oral contraceptive pill? My first step is assessing whether the patient is at current risk for pregnancy. Has she had recent unprotected sex? If she's had recent unprotected sex and she doesn't wish to become pregnant, and that unprotected sex occurred in the last 5 days, I would think about using emergency contraception before starting her on a combined oral contraceptive. If not, I would start contraception today. And the recommendation would be that she would need to use a backup method like condoms for at least 7 days in most cases. There are a couple of exceptions, like if instead of a combined oral contraceptive pill, I'm using a copper IUD, she doesn't need to wait that long with a backup method. But in general, for combined oral contraceptives, you can start now. There's no need to wait till the next cycle, but she will need to use backup method contraception for at least a week. I mentioned this a little bit earlier because we were talking about assessing for recent unprotected sex, and I wanted to take just a minute to talk about what I can offer in terms of emergency contraception for women who have had unprotected sex. So there are 3 FDA forms of emergency contraception. Clearly, this slide is giving us a hint that the first of those is the copper IUD, which is also called the Paragard by brand name. The copper IUD is by far the most effective form of emergency contraception. It's 99.9% effective, meaning that very, very few women in the first year of use become pregnant. It can be used within 5 days of unprotected intercourse to prevent pregnancy. The copper IUD is both emergency contraception and a great long-term contraception plan. The biggest issue I would say with the copper IUD is that it does require a healthcare professional for insertion and for removal, and so it can't be inserted right away or done over the phone in this COVID era. The next option that I always talk about is ulipristal, which goes by the brand name of Ella. This is the second most effective form of emergency contraception. The risk of pregnancy is reduced by 62 to 85%. It can be used up to 5 days after unprotected intercourse, but it is available by prescription only. It's also really important to know that Ella interacts with hormonal birth control. Ella works mostly as being an anti-progesterone, and most hormonal birth controls have progesterone in it. So what I tell people is that an anti-progesterone plus progesterone means no emergency contraception and no regular contraception. That being said, I will routinely prescribe Ella for patients of mine who are using barrier methods as their form of contraception, because it obviously doesn't interact with barrier methods, and barrier methods are less reliable than many of the other forms of contraception that we have to offer. The last form of emergency contraception that is FDA approved in the United States is Plan B, which is a high dose of levonorgestrel, 1.5 milligrams. The risk of pregnancy is reduced by 60 to 90%. And I know that that looks like it's as effective as Ella, but we actually think Plan B is not as effective as Ella. Plan B can be used within 3 days of intercourse, though there are some people who would say you can use it up to 5 days later. It's just that the efficacy decreases dramatically after 3 days. It's really important to know that Plan B, or levonorgestrel, is thought to be much less effective in BMIs greater than 25, which is a significant proportion of the American population. But Plan B has the advantage of being an over-the-counter medication that doesn't interact with hormonal contraception. So when I have patients who are on birth control pills, I often will also write for Plan B so that they have a backup plan on hand in case something were to happen, like she were to forget her pills or run out of pills early or whatever. The last practical nuts and bolts question is what to advise patients when they call the after-hours emergency line saying, "What do I do? I missed a pill." If she just missed one pill, I tell them to take it now. If she realized that she missed yesterday's pill because she went to take today's pill, it's okay to take 2 of the oral contraceptive pills at the same time. If she's missed 2 or more pills, the recommendation would be to take 1 pill now, take the next pill at the regular time, and then use backup contraception for at least 7 days. If she's had recent unprotected intercourse and she's used 2 or more pills, I would also consider using emergency contraception. And that would be Plan B, not Ella, because Ella and contraceptive pills interact. The last thing we're going to talk about in this portion of the lecture is how to initiate this conversation with patients. And I like the 1-question screen, which is, after I've determined that the patient is sexually active with men, I will ask, would you like to become pregnant within the next year? Because that gives me a really good sense about whether or not we should be talking about contraception, and it's a really helpful conversation opener. After I've used this question, I often then will ask a patient, what is important to you about your birth control method? Because this gives me a lot of really important information. I think as providers, we often think that the most important thing about birth control is its efficacy in preventing pregnancy. And that's a really important factor for many, many women. But it's not the only or even the most important factor for some women. So some women tell me that the side effects of the pill are what worry them the most. Timing for other women is the most important thing. They want something that they can control, or they want something that they don't have to think about every day. And periods is the other thing that I always ask about when I'm talking to women about birth control. Do they have any strong opinions about their periods? Some women will tell me that they don't want a form of birth control that might put them at risk for amenorrhea, where they would lose a period while they were on the pill. Others tell me that they just want a birth control pill that makes their periods predictable or that reduces the risk of breakthrough bleeding or unpredictable bleeding. That's really important for me to know when I'm providing contraceptive counseling, because different forms of birth control have different impacts on menstruation. We're going to pause here, and I'm going to have you watch the next video, which is all about cases. I hope that this video has given you some practical tips on how to start hormonal contraception and how to start a conversation with patients about contraception.